Hello. Hi.
Hi, Ryan. Welcome. Glad you were able to connect.
Yes.
Uh, we are live now, and I gave you the rights to share your screen. And
Okay.
when you do that, Ryan, just make sure that you check the box that says share computer audio as well, because I know you said you have some sound that you want us all to hear.
I do. Gotcha. Should I do that now?
While Ryan is getting his slides set up, let me welcome everybody. My name is Barry Hoffman. I'm the Associate Dean for Clinical Affairs in the College of Health Professions and Sciences. And on behalf of the college, we're very excited to bring back for the second month our new series, Up to the Minute in Clinical Care. And today we're going to be discussing the role of music therapy in interdisciplinary care. We have two amazing speakers, Ryan Tonkin, and I'll introduce in just a second, and Dr. Amy Engelhoven from the University of Central Florida. I want to just mention before I introduce and share a little bit more about our speakers that we will hold some time at the end for some questions. As questions arise during this session, please type them in to either the chat or the question box. And we'll make sure that those get asked of our speakers before the session ends. We're also recording this if you want to go back to it in the future or share it with other colleagues. So let me just share a little bit about Ryan, a very impressive bio here, and I think it's important for you to know the expert who's delivering some of the content here. Ryan Tonkin is a board certified music therapist. He attended the University of Miami and received his bachelor's of music and music therapy. He interned at the Veterans Home in Yountville, California, providing music therapy services to a wide range of populations, primarily working with adults in assisted living and skilled nursing facilities. He also established the music therapy service line for young veterans recently returning from Iraq and Afghanistan, with a treatment focus on substance abuse and PTSD. Ryan has extensive experience working with the adolescent and adult inpatient psychiatric populations. He worked from 2011 to 2014 at Central Regional Hospital near Durham, North Carolina, working with an interdisciplinary team focusing on substance abuse, coping skills, medication management, emotional recognition, and all within the acute psychiatric patient population in a large forensic population setting. Since 2014, Ryan has worked with the Orlando Health Organization in Central Florida. It's the only level 1 trauma center. Populations served are primarily oncology and trauma, but include services in the hospital for a wide range of patients admitted to the Orlando Health System. Ryan is the program coordinator for music therapy services at Orlando Health, including the music therapy internship program. So very impressive. And before we turn over to Ryan, I won't have an opportunity to introduce Dr. Amy Engelhoven, who is a lecturer and the director of the Aphasia House in the School of Communication Sciences and Disorders at the University of Central Florida. Dr. Engelhoven has extensive clinical experience in acquired adult neurogenic communication disorders and voice disorders. Her academic teaching experiences include neuroanatomical bases for speech, language, and hearing, adult language disorders, motor speech disorders, dysphagia, and voice disorders. Her research interests include the psychosocial implications of acquired neurogenic communication disorders, caregiver quality of life, patient-reported outcomes for persons with aphasia, and evidence-based treatments for aphasia. So the Aphasia House at UCF offers student-led intensive comprehensive aphasia programming that provides 5-6-week intensive treatment. Dr. Engelhoven provides the clinical supervision in this special clinic 4 hours each day, 4 days a week during those sessions. And I know she'll talk more about that. So without further ado, I'm going to turn over the session to Ryan, and we're looking forward to it.
All right. Thank you. Let me go ahead and share my screen. Oh, it wants a password. I apologize. All right. Awesome. Well, first of all, I'm really grateful for the opportunity to be able to speak to you all. whoever happens to be out there. A few disclaimers to begin with. Um, I'm not the most well-versed human. What I am is a very fortunate individual who has been able to work side by side some just fierce clinicians here at the hospital, and that has made all the difference in the clinical care and the work that I do here. I really, and especially as I talk a little bit, I really want the focus to be on the collaboration that happens and not me and not the specific services that I give. Again, together we are better together. So also another disclaimer, I'm going to say specific names. That is on purpose. I have all of their consent to do so. Names of clinicians here. There's a few reasons why. One is to try and embarrass them, because it's kind of my personality. Another is I really feel that it's important that we use their names and that people can know of some of the fantastic clinicians here. It is important, and it's important to me. So that's a few disclaimers there. So we can get going here. So purpose, I want to take some time to define music therapy. We've all heard the words music and therapy. We combine them and I know what that is. Sometimes we're kind of close, sometimes maybe not so much. So I want to take some time to be able to define that. I also want to paint a hopefully accurate picture of the work that is done here, the music therapy services that are provided here. Also give some, I guess, more framework of music therapy and kind of delve in a little bit more, building upon the definition of music therapy. And then talk a little bit about the collaboration, the interprofessional collaboration, and the music therapy services with the other clinicians here in the hospital. And to summarize and kind of put another bookend on it at the end is to talk about some case conceptualizations and really just some real life examples of how this all went down, of music therapy services collaborating with other people. I wish we were face to face. I thrive off of that type of interaction. And then there'll be some questions and answers at the end here. But again, please feel free to ask any questions, type them in. There should be a chat box or a question and answer box. So please do that. All right. Question of the day. So what is this music therapy stuff? This is the textbook definition. My elevator speech that I typically give people is music therapy is the clinical use of music to address a non-musical need. And music therapists in general, the way I like to, again, kind of encapsulate that for people in a bite-sized chunk is that there are therapists that have music as a tool to use. So currently, entry level's bachelor's degree or higher from an approved university. These are just some of the clinical hours, the trainings that you need to do. The MTBC is the credential for music therapists, and then 100 CEUs need to be gained every 5 years for your recertification.
So Brian, can I just stop you for just a second? How did you get involved in this? Were you a musician as a younger person, or?
So that's a great question. Yes, so I played music growing up and everything, and one of the one of the subjects that really piqued my interest, starting around maybe early high school, was psychology, and I knew that I liked helping people, and so I actually was initially a music education major. Went to school, realized within probably the first semester or so, like I don't know if I want to do this, but so I was going to actually double major in psychology and music, and then be able to use the psychology degree to further my education. And my advisor said, well, have you heard of music therapy? And I said, yes, but my knowledge and kind of just the way that I perceived it at the time was not super accurate. So he set up a meeting with the program director of music therapy at school, and that's kind of what happened. So here I am. So how it started here, the services, there's a wealthy community member. He heard of music therapy, but only for pediatrics. And he thought, hey, let's get that for the adults. So he funded a grant for 3 years. It was placed under the Department of Integrative Medicine, which is part of the oncology service line. And then this is just kind of a progression here. Education, networking, outreaches, services were picked up by the hospital after the grant ended. So I've been here about 6.5 years now, and very fortunate to still be here. And Joy Willette is the most recent pretty much the most recent member of the team here, but the other music therapist here. And she is someone that I work closely with every day, someone who I can collaborate with, who can support me, have a different perspective. And so someone that is integral to the work being done here as well. So I mentioned integrated medicine. What's that? So this is the department here, but that's, again, is the textbook definition. I'm not going to bother reading that. You can all read, but I do want to make note of this, is that a key, I would say, paradigm that is within integrative medicine is that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So just because someone gets fixed or cured of the ailment that brought them in does not mean that they are healthy. And so integrated medicine, music therapy services, really the clinicians here that I have the privilege to co-treat with, they're all on board with this, whether they know it or not. And it shows in the clinical outcomes that we all achieve together. So some defining principles here. Again, I'm not going to read through these. I realize with the time here, I'm probably going to run out of time. So I'm going to try and bust through some of the stuff so I can take more time later on. Again, basically, there's a partnership within the integrative medicine modality that includes everyone, which if that is not interprofessional collaboration, I don't know what it is. Disclaimer, integrated medicine, music therapy, these type of services is not the same as alternative medicine. I will never, ever go to a patient and say, oh, like, yeah, you don't use your chemotherapy. Just, listen to Led Zeppelin, like, no, what? No. This is, the alternative medicine is not the same as integrative. So I just want to make that point. So kind of the scope of practice here, and then the next slide will be more about the workflow, but essentially we accept referrals from pretty much anyone here in the hospital, as it kind of says here, but kind of the workflow here is part assessment. So again, I'm going to kind of buzz through this stuff, but we'll look at their charts, do a chart review. Again, look at some of these issues, look at the psychosocial domains, look for cognitive communication, physical issues that may have brought them in here or just may be pre-existing. And then obviously the music. One of the backbones for music therapy research is the use of preferred and familiar music. So essentially music that your brain knows and that it can predict. And there's a lot of research to indicate basically that if that is your foundation for the musical selection, whatever type of intervention that you are doing using music, it's going to make it better is the way I'll say that. So again, here we go. This is kind of more of a workflow here, but starts with a referral consult. We do an assessment. So this is typical medical modality treatment stuff, right? So creating a treatment plan with goals and objectives, implementing a set of interventions to address these goals and objectives, evaluating the patient's response to the plan. Oh, look at that. Collaborating with other disciplines as indicated, documenting change in progress, and then really being flexible, evolving the treatment plan as the needs change. And then, of course, when their time is up here at the hospital, we know discharge is coming, the proper therapeutic termination of sessions with the patients and their families. So who do we see here? We cover 3 different hospital buildings. We're at the downtown campus here. So it's all the medical units. So I'm going to blast these up here. So general medicine, progressive care units, the oncology units, general surgery. So then also ICU, neuro, and burn trauma ICU, neurology. And something unique here is we have an inpatient hospice unit here and also an inpatient rehabilitation unit. So this framework in the next few slides, it's going to be more specific to answer the question of but what is music therapy? Like, what does this look like? That's one of the more common questions that I get asked. This is also when I would ask you all that and then get some feedback, but that ain't going to happen today. So here we go. In general, I get asked a lot about music and kind of the specific, like the actual music part. So a vital component to effective music therapy is harnessing and manipulating the elements of music at will. This can be in the moment or planned ahead of time in order to best facilitate interventions based upon the patient's needs. So here are some of the elements of music that I guess are more prevalent and more pertinent. Okay, so these are Again, this is strictly music stuff. So notes, articulation, technique, emotion and the feel, dynamics, rhythm, tone, phrasing, space, listening, lyrics. I would say the ones here that are manipulated the most are going to be notes, the emotion and the feel, dynamics, rhythm, and if we can manipulate them, lyrics. So these are kind of some of the domains that music therapy interventions will address. There are 4 categories, I would say, of interventions. So again, this is further, hopefully further answering like what is like a music therapy intervention. So they can be one of these 4 different categories. So receptive, which is just like it sounds. You're receiving something. I'm not asking you to hit something or shake something or sing or do, you know. Recreative, so this is learning and performing a pre-composed song. Improvisational, just like it sounds. We are going to spontaneously create something in the moment together. And then compositional, we are going to work together to create something that didn't exist before, but it's going to exist now. Expanding upon that further, there's going to be there's a few different theories and models of the levels of practice of music therapy. I chose to use one by Barbara Wheeler. She first kind of started to talk about this, I believe, in the late 80s. So the first level here is supportive. As it says, is activity-based, success-oriented. It's very here and now. It's very kind of gestalty, if you will. It's what's going on in the room right now, and how are we using music? How are we manipulating these elements of music to curb a behavior or to obtain some sort of desired outcome? And these are just some examples here, some goals, some interventions, and then example populations. Again, this is none of this stuff is indelible, just you know, like lines here separating these. It is more of a gray area at times. The second level of practice, according to Wheeler, is going to be this re-education. So emphasizes interpersonal relationships and processing emotions. This is probably the level of practice that is most commonly used here by Joy and myself. The running joke is that, oh, you guys make people cry, which happens quite a bit. The cathartic release, the person experiencing an emotion that has perhaps been repressed, an emotion that needs to be unpacked, if you will. Music cuts through that like any of those barriers to experiencing that emotion like a hot knife. And as long as the therapist is skilled enough to, again, like this says, be able to choose something, a song or a piece of music, it really is a great catalyst for the work. For the work going on with the patients after that. As it says also in that other in the first bullet point there, that's really where the solid verbal processing skills come in. That's space for other modalities of counseling, whether it's some sort of CBT, REBT, some sort of psychodynamic approach, but whatever that may be, that's kind of the space that would fill. Here's more example goals, and then some more interventions here. And then again, some example populations maybe that this level of practice would be more suitable for. Third, reconstructive purposes to uncover, relive, or resolve subconscious conflicts. This is also, I believe, a level that is used frequently here in our sessions. Again, example interventions. Example populations. All right. So some stuff I just wanted to talk about. I know that was a lot and I kind of rambled on through it, but specific to the modality of music therapy, and I think some of the things that are going to ensue now are going to indicate and show why interprofessional collaboration is essential. So music therapy is a process-oriented field. It's not task-oriented. Of course, there are specific tasks and goals that we have for obtaining, obtaining in the work with patients, but it is not, you have problem A, I'm going to give you pill B, and 99% of the time we will get C. It is not linear. It is more like this type of a process. So it is process-oriented. Another dynamic here is, a lot of times someone will say, and there's nothing wrong with this, but they'll say to me, oh, like I was doing my own music therapy, like I was listening to music and it made me feel good or whatever that made. Like, yeah, like that's awesome. Like music can be therapeutic. The difference though is that, example, if let's say I were in LMHC and we just had a conversation about I don't, politics, since that's like a thing right now, and then afterwards you're like, oh, it's a great therapy session. It's like, no, just because my profession is this doesn't mean that we just had a therapy set. Like we're just talking. Like I used words and listened and then spoke and listened, and we kind of had this thing. And but it doesn't mean you just had a counseling session. So same thing with music. Not all music and the use of it is music therapy. So again, this is a very dynamic process. It's always evolving. It just, in the second you think you got it figured out, it changes, makes a fool of you, keeps your ego in check. Something that is very important also with the music therapy modality is this thought of person in their environment. I believe, so yes, with some of the integrative medicine charges that are stated, that is one that is taken into account. I believe social work also, in the social work studies, are kind of a big supporter of this whole person in their environment and in the interplay and the dance that these two things have. Working here, again, there are population specific needs. So you're going to hear me talk about trauma-informed care a lot. There's a specific bottom-up approach that I personally use a lot here, and it's important to, again, be aware of these things and to be able to know when and how to use them. Again, like as when Barry was saying that in the beginning here, that a lot of the work I do is with trauma and oncology patients, being aware of the medical side of cancer, for example, again, is a very important role here. It's, although obviously I'm not going to be doling out medication, knowing when side effects may come up and when a good time to meet with a patient may be, or things to look out for. Again, these are all involving the person in their environment. Other things that come up: boundaries, self-care. Self-care is a very it's a hot topic these days, especially on social media. I think due to COVID, but either way, I'm glad that more of the conversation is starting about self-care. And then some ethical considerations, and I think maybe you'll kind of see in the case conceptualizations, see why these are kind of important dynamics in the music therapy process. So, all right, co-treating with other clinicians. Here's the good stuff. I would like to say this first. In thinking about this and kind of putting together this presentation, it really gave me the opportunity to reflect back and even just kind of rehash some of the old patient cases with some of the other clinicians here. And it really left me with a sense of gratitude of the amount of collaboration that happens here. And sometimes it's not even at the forefront of our minds. And for myself and some of my other colleagues here, and we just do it. And I cannot help to think that it makes us better and it makes patient care better. So I just wanted to say that. So some definitions and benefits of interprofessional collaboration. So this is taken from some research literature. Collaboration occurs when two or more entities work together to produce a desired shared outcome. Oh, that makes sense. From here on out, I'm going to refer to it as IPC, just for continuity, and I don't know, that's what the research said. So that's what we're going with. IPC is linked to better outcomes in family health, infectious disease response to epidemics, and non-communicable diseases. Sounds good to me. Show improvements in access to care and coordination of services, appropriate use of specialty care, chronic disease outcomes, and safety. Good. IPC has shown to decrease complications and error, decrease length of hospital stay. That's a big one in hospitals. Conflict among caregivers, staff turnover, and mortality rates. All right. There were a lot more theories on this than I realized when I started to look into this. I was like, oh yeah, like we work together and like it's better. But there's actually quite a few different theories and theoretical frameworks that are presented in the research literature. It was interesting. I think starting around like the 70s, people actually started to specifically look at this. But there are common themes, and I tried to pick out some of those common themes here. So one of them is sharing. So we share responsibilities, decision-making, values, data, planning, and intervention. Second main concept is partnership. So mutually respectful, authentic, constructive, contains open and honest communication, that communication part, and awareness of values and contributions, perspectives of other professionals. Third one here, interdependency. We depend upon each other to, again, all funneling back to addressing the needs of the client or the patient. This was also brought up in a lot of the literature here that I was looking through, is that as the complexity of healthcare problems increase, obviously the demands for treating these complex problems increase. And so actually IPC is indicated to help better address the needs of the clients. And the fourth one here, power. Product of relationship and interactions between the team. So essentially that the power combined is going to be greater than the individual. And this power is shared among team members. This last part is interesting. So the power is based upon the knowledge and experience of the people, not their functions or titles. I will say this is that in the acute care hospital setting, functions and titles mean a lot. And again, I think in some of these other concepts beforehand is that if we can learn to, in these psychological terms, essentially silence our ego and to be open and neutral enough to ask questions, to be humble enough to, again, to swallow our pride and to just say, hey, like, I don't know, this isn't my expertise. Like, what do you got for me? Is something that is an integral part of IPC. Like I said, yeah, I think I actually had mentioned this earlier, but some theoretical frameworks have been kind of around since the 70s. Also, something the research was saying is that we don't know that much about these complex dynamics, and perhaps it's an area of study that's needed. Again, here's some more common themes here. Again, it's all client focused. It's person centered. It's however you want to say that, but that's what hopefully that the team mentality is about. This IPC mentality is about. Contains a team that integrates the perspectives of each professional. Again, if I'm co-treating with a speech language pathologist and someone is on mechanical ventilation and they have trach, and they're going to try a trach trial for the first time, and I'm there to try and facilitate some sort of meaningful speech output or interaction, or just to see if I can distract them while they're off of the ventilator for the first time. I need to know that's safe. It's not my wheelhouse. I'm not an expert in any of that stuff, but there are always going to be people around you here who that is in their wheelhouse, and they are the expert on that.
Hey, Ryan, I have a question about this IPC concept. When you were in your bachelor's program, becoming a music therapist, was this programming embedded into your program, or was this something that you had to tackle as you got out into the field and started getting your clinical hours? And how do you feel like that? Should it be more integrated in the academic program itself?
It's a great question. So to answer your question, yes, it was. So my schooling was in neurologic music therapy, which was really tailored towards neurorehabilitation. And so, example, if we were doing some sort of gait training intervention, it was always premised with get a physical therapist. You don't mobilize the patient. Obviously, that's not my expertise, but using rhythm to have them in train, and then hopefully, increase their gait, essentially. That is something that I can do. And so we were encouraged to, let's do that. If we were encouraged also, let's say if there was some sort of like melodic intonation therapy that we would be doing, find a speech path, ask them, see how the patient presents, pick their brain. I will say, and then on the other hand of what you asked, I have learned and been able to hone my craft through asking questions just throughout my, whatever it's been, 10 years or so, 11 years or so of being in healthcare. I constantly find, and I don't think anything to any detriment to myself, but I constantly find holes in the services that I provide. And there are people though who can fill those holes, who, again, that is their expertise. And so that burden is on me, again, just to pony up and ask them. And so that is, but again, that has made all the difference, I think, in the work here that I can do with patients. So these are just kind of some brief general IPC examples with music therapy that happen here. It could be something simple as someone putting in orders. So actually they all are, since I rarely put in orders for myself here, because that's odd. From nurses, advanced practice providers, doctors, a lot of them come from the rehab staff here. So physical therapists, occupational therapists, and speech language pathologists, and then obviously the mental health folks here as well. So the licensed mental health counselors and the licensed clinical social workers. So some examples, just very brief examples here of IPC in the past. Palliative care physicians, so co-treating to support patients and family with end-of-life dynamics, perhaps some maladaptive coping that's come up, or maybe transitioning to hospice. As an example, I got a text message, this is maybe last year or so, and said, "Hey, Ryan," it was one of the palliative care doctors, and it was, hey, Ryan, basically there was a husband that was, I'll say freaking out, but he had a very high emotional burden of a decision that he needed to make for a loved one. And the overt emotionality that was escaping him was jarring. I'm trying to be as diplomatic as possible here. And so he said, "Hey, can you come with me and we can support this patient and see what we can't do and work with him." So that's what we did. Rehab staff. Perfect. So again, just kind of some examples of IPC that happen with some of the rehab staff here. So facilitating discussion of realistic goals and care, perceived outcomes. A lot of times it's going to happen. Actually, I should have put speech in there as well, but with PT, OT, and speech. In the trauma realm, again, providing trauma-informed care, emotional support, end-of-life dynamics, using AAC. So a lot of times this is with some of the awesome speech paths that work here. Same thing here. So spinal cord injury, specific coping issues too, obviously adjusting and I'm sorry if you can hear that, and using the, or adjusting to the new life changes of having a spinal cord injury and maybe resulting quadriplegia or paraplegia. Speech communication, rehabilitation. This is fairly popular, I would say, in acute care, but not ICU per se, but maybe once they're moved to a less acute unit, and then definitely on the inpatient rehab floor. And then obviously with nurses, a lot of the referrals come from nurses who just throughout their day, they're very busy. They're doing a lot of different tasks and they think, oh, that person's crying. That's not typical right now. And so maybe that's enough for them to put in orders for music therapy. And then again, that starts that conversation during the assessment process of me contacting them and saying, hey, I saw you put in orders for emotional support. How can I help this patient today? Right. Indications for music therapy and for this IPC again. There's a bunch of research to back this, but I had actually reached out to some of my coworkers. I wanted to keep this a little bit more pertinent, I guess, to specifically here. And so a couple people had who I'd asked, who I'd co-treated a lot with in the past, or who I know I've been in the trenches with here with some of the patients. Christina Lynn, one of the speech paths here, and Rachel Gonzalez, one of the physical therapists here, to again, just fiercely good clinicians who I had the privilege of working with. So these are some of the things that were brought up in some of our conversations. So indications for music therapy services: history of psychiatric issues, so suicidal ideation, homicidal ideation, previous diagnosis of some sort of psychiatric issue. Traumatic injury could be just a complex medical case that will alter previous lifestyle or have long-term impact on the patient. Deaths, a lot of death and dying here, just the way that it is, a lot of grief work. People die. People die every day, and our society is not great at dealing with that, and the individual is not great at dealing with that. Distressing event, unique circumstances. Some of these conversations are my favorites. Like, Ryan, they're just something's off, something's not right. And so again, that will start our conversation. We will figure out a way to co-treat with them if indicated, and at least be able to keep each other up to date on the progress that is being made. Obviously, a need for emotional support, need for additional insight in interpreting the emotional state of a patient. Again, like I said, rehabilitation of expressive language. Benefits that have been seen here. Improvements in mood, increased participation actually in the other therapies. Improved coping strategies, more authentic presentation of patients, which has been then correlated with better outcomes from the other therapists as well. Increased motivation for communication use. I think some of the first collaboration that I was doing was with, I think it was earlier on with some of the speech paths here, of a person maybe who was having a PMV trial for the first time, or just had a trach and just, could not verbalize. So we need to figure out other ways to communicate with them and to process, and to kind of unpack some of these emotions that are very common and that will are very common elements with people with trachs. Family support, continuity care, increased awareness of psychosocial elements. Again, that is from the other clinicians. So the fact of just, we have this dialogue now of, I'm not just caring about their mobility. It's, why are they crying every time? They're not in pain, but they're crying every time that we're stretching them. It's like, well, what's going on there? All right, this, all of that was to get here. I wanted to, again, hopefully paint a picture of what kind of the dynamics and what this would look like in working with other people. It could be co-treating actually in the room and being there. It could be a conversation outside. It could be a follow-up discussion. It could be, again, it's a very dynamic process. So first one here, this patient, initial consult was received from an occupational therapist here named Courtney to address the emotional needs of a patient due to a new spinal cord injury. She was a 24-year-old Caucasian female. Status post motor vehicle crash resulting in C5, C6, subluxation with central cord, so she had incomplete quadriplegia. The kicker, at the time, she was 27 weeks pregnant. This resulted in an emergent C-section, and ultimately the fetus died during her admission here. Continuing on, this is just some of the general medical info about her, kind of just trying to shed a little light on the progression of things. And some other key components here, which a lot of this info obviously was observed and from me reading the chart and working with the patient, but also just maybe an occupational therapist would leave the room and it would be like, hey, like, how did they comply with treatment today? Like, how were they with you? It's like, well, it was good, but she kind of got tearful during this one part. Like, do you remember what was going on during it? So again, there's more of that collaboration. This patient had a great social support system. Her religion was very important to her. She eventually was discharged to an inpatient rehab facility out of state. So with this patient specifically, some of the goals, interventions: improve sense of safety. So mitigate the PTSD likelihood and symptoms. Basically, research strongly indicates if you try and unpack emotions after a traumatic event too soon, later on, actually it makes PTSD symptoms worse. So sense of safety from this bottom-up approach of trauma-informed therapy is the first move. Decrease anxiety for her, improve stabilized mood. Again, using that trauma-informed care, that bottom-up approach. Something that was unique about this, and this kind of, again, was a team effort of everyone being supportive of this patient in their own specific way, but she was part of a research project I was doing, and I would ask the same questions. It was looking at music therapy interventions for spinal cord injuries and on pain and anxiety. And I asked her quite literally the same question, because I had to, every day that I met with her for weeks. And I would ask her essentially, rating her pain on a scale of 0 to 10, 0 being no pain, 10 being the worst pain. And one day, just out of nowhere, she stops me. She said, "Do you mean physical pain or emotional pain?" Up until then, that there was no emotionality, no nothing. Her brain was not ready to go there. And this was really the big indicator of, hey, she felt safe enough, and now it's time to allow my brain to go there. Things that also came up, obviously grief work with the death of the baby. Trauma-informed care, social connectivity is incredibly important. She had a husband. He actually happened to play guitar, and he had a guitar. I think someone had donated one or gifted him one. So we actually were able to use music again that was preferred and familiar for the patient and do an intervention together. I also came in on the weekend and did a session with some of the friends. Again, that social system, that tribe was plentiful but scattered, and it was indicated for some further work to be done with them. Another patient here, moving on. This initial consult came from one of the care coordinators from one of the trauma teams here. It's a 41-year-old Caucasian male, necrotizing pancreatitis, cleaned him out, multiple surgeries to address all these GI issues that came up. Essentially, what ended up happening was multi-system organ failure, acute respiratory failure, sepsis. All of these issues came up. This is the general progression. Came in, emergent surgical interventions, continued surgical interventions. Eventually, the patient was made DNR, no more surgical interventions, and then eventually inpatient hospice care here. So some goals and interventions. Increased relaxation response, comfort, relaxation needs. Again, everything kind of shifted to the end of life issues. I believe it was about 3 weeks that I was working with this, maybe 3 to 4 weeks as me working with this patient. And again, I'm going to kind of rush a little bit here, but what I did want to show is some of the collaboration that happened with this patient. And this was actually with some of the nursing staff who they had expressed to me the need for, again, just further emotional support in this grieving process. This husband and wife had a couple young kids. And so what I did was to do a heartbeat project. And what was unique about this, and basically these heartbeat projects are part of what we call legacy building. They are when I can go into a room with a special electronic stethoscope. I will record a patient's heartbeat. I will edit it down later and kind of copy and paste it, essentially making one very long heartbeat. On top of that, I will then superimpose, it could just be words, but most of the time it's a song. So their heartbeat becomes like the rhythm, like the drum, the rhythm of a specific song. And so in this place, it was the song that's played at their wedding is what this patient wanted to then be used and superimposed over his own heartbeat, so that after he died, his wife and his kids could have it. So I kind of already mentioned this. All right, I don't know. Well, I mean, hopefully you're all listening, so you have speakers. I'm hoping this works. I actually am going to play a little bit of this song.
There's something that I can't quite explain. I'm so in love with you, you never take that away. If I've said it 100 times before, you expect 1,000 more. You'll never take that away. Expect me to be calling you to see if you're okay when I'm not around, asking if you love me. I love the way you make it sound, calling you to see. Do I try too hard to make you smile, to make you smile? I will keep calling you to see if you're sleeping, are you dreaming? If you're dreaming, are you dreaming?
So yeah, that's just an example of a heartbeat project. And it's not the easiest thing to hear the heartbeat. I hope some of you, at least on some of your speakers, could hear the heartbeat in the background over that. Again, being able to then use this as a catalyst to process death and dying, the grieving process, it really is a privilege to be able to do that with people. How are we doing on time here?
Are we wrapping this up at 11:50 or at noon? Megan and Dr. At noon. Okay, so we have about 15 minutes. So maybe another conceptualization piece, and then we can turn it over to questions and answers.
Sounds good to me.
All right, great.
All right, let's see here. All right, we're gonna do this because this just happened 2 weeks ago. So a consult came in from two of the speech paths here, Heather Capel and Tiffany Moore, for legacy building, same thing. Let's see here. This is a 75-year-old male, heart attack while on his bike. Brain bleed, but C2 cervical fracture is intubated, so resulting in quadriplegia. Interesting about this case, the wife actually was a former ER nurse, and she had pretty good understanding, I will say, of his medical condition and the poor prognosis, or at least the quality of life that would ensue after. Goals of care quickly shifted to comfort care and ultimately withdrawing care, essentially turning off the ventilator, resulting in the patient's death through the support of the palliative care medical group. He had two daughters, came into town to be with the patient and the wife. This happened quick. He was admitted on Sunday afternoon. He died Tuesday afternoon. So music therapy here and some of this collaboration. So again, I got a call actually first for this one, which whenever I get a call from one of the rehab staff, it's normally something unique. So that was nice. The call was about end-of-life dynamics and communication needs. So this is what they essentially had presented was, Ryan, we are trying to use some AAC to give the patient the opportunity to communicate and to facilitate the last conversation he's ever going to have with his daughters. It's like, oh, well, happy Monday. And his wife, right? So this was more co-treating with speech language pathologists in the room. It started with a warm handoff. So they had already been working with the patient, and it was, again, them introducing me and kind of briefly going over my services, or at least the purpose of my presence in the room. Together working to using again, they have I believe it's called the Toby Box device. Anyways, it's a specialized device that's used for, it's a very high-tech device used, again, for different types of communication. And they were looking to create boards of phrases that the patient could rest his gaze upon that would then be selected for him to be able to communicate some of his last wishes, or at least express some of his feelings to his wife and his two daughters for the last time. So we're going to go through this a little bit here. Ultimately, his cognition was not at an appropriate level to proceed using the high-tech device. So it became low-tech, and which was, again, just fine. Some of the music therapy aspects, and even some of the conversations with some of the speech paths in the room were obviously mortality aspects, final conversations with therapy. Uniquely, one of the interventions that I used in the room was this song. So Michael Rowe, The Boat Ashore. Apparently, the patient played guitar to his kids when they were younger. So the wife was like, this was like their song. They would like sit around. This is like a thing. So I used live music in the room. Again, this would be a recreative I said receptive. This is probably more recreative, where they were able to hold their father's hand for one more time. And have that connection with him, creating that safe space. This is also interesting. The patient had an emotional reaction, cried. He's hardwired in, so spike in heart rate, again, indicating an emotional response to this. And again, I also recorded his heartbeat, and they requested that the song used in session, Michael Roll the Brochure, would be the song used for this heartbeat project. So I had one more. I'm going to skip it. And I apologize if you can hear the...
So while you're skipping through these, Ryan, I have a question for you. And I know that we're going to have other questions that are probably going to come in, but you deal with a lot of really heavy circumstances in your day. And so how do you debrief and manage a lot of that? Because I got a little teary listening about these heartbeat projects. I mean, I got to say that was very unexpected. So can you tell us a little bit about how you debrief and manage your own emotions as you're dealing with this?
Absolutely. That's a great question. One of the slides I had mentioned self-care. The way that self-care is presented these days, in my just humble opinion, is kind of a bastardization of something that is incredibly important and needs to be taken incredibly seriously. And it's not. It's drink a glass of water and go for a walk and you'll feel better. It's like, nope, that's not actually how that works. Again, I could speak for hours on self-care, but I'm not going to. But for me personally, being open and honest with myself, if I need a break, taking it and knowing it's not giving up, I just need a break. For me, something I respond well to is the support of some of my tribe. I use the word tribe, but some of my close coworkers here. Again, I do believe that is also a form of IPC, is being able to debrief, is being able to vent to each other. And for me, that makes all the difference.
And I'm sure that you have a lot of positive. It's not always super heavy. You know, you and I talked yesterday about the viral video of Congresswoman Gabrielle Giffords, when she was shot at a rally. And she is one of our more famous representatives of persons with aphasia. And they were doing music therapy with her when she was in the rehab center in Arizona. And it's, that seeing that kind of reaction from a person who is unable to communicate has to be really a very uplifting emotion for you. It kind of makes you feel, this is why I do my work.
Yeah, you're right. It's not all doom and gloom. There are definitely times when, like seeing a person speak for the first time after a stroke, when they thought maybe I'm never going to be able to speak again. Seeing their facial expressions, seeing that they're just emotive, just pure visceral like reaction. Yeah, it's amazing. It is absolutely amazing to see. And it's humbling, and it keeps you coming back for more. Yeah,
absolutely. We have a question. We've had 3 questions. They're all kind of the same question, so I'm going to kind of blend them together. Your attendees are asking, do you have to be knowledgeable in music, such as playing an instrument or being able to read instrument, to become a music therapist, or should I know how to play an instrument? What are the general requirements to be a good candidate in a music therapy program?
Sure, that's a great question. Every music therapist, so when they go to sit for their board exam and then just through your training, you have to be, the term is proficient. So you don't have to be Jimi Hendrix, but you can't not hack it. But essentially, you have to be proficient on piano, guitar, voice, so singing, and using like auxiliary percussion instruments. Again, you don't have to be this outstanding musician. As one of my slides indicated, though, I will say that the more skilled you are, especially at piano and guitar and voice, I think that the more unique and better interventions you can deliver.
Awesome. Over here at Aphasia House, we have several programs that we try to offer, one of which is our UCF Adaptive Community. And as I mentioned to you, but our attendees may not know about, we have an adaptive theater and adaptive sports, as well as an adaptive choir. And our choir over here, while it may not be a skilled music therapy intervention, so to speak, I can tell you anecdotally that it's a very therapeutic experience for our individuals who participate in it. And they do a performance in the music department each semester. We haven't been able to since the fall because of the pandemic. Hopefully we can pick that back up very soon. But I think it would be a wonderful opportunity for our program, as well as other music therapists or other music therapy programs in the area, to collaborate on. I think it would be a good early start for that interprofessional collaboration for sure.
Let's do it. I'm all about it.
Can you share how you developed the program for Orlando Health and other organizations?
Yeah, so especially within the medical modality here, research goes a long way, and knowing what is, just being up to date on the science of things, especially in a profession that uses music. It's very whimsical at times and might kind of be a little woo-woo at times for people. This is founded in science, though, and being aware of and able to communicate some of the data and just some of the research that's out there really bodes well for that. One of the bigger things that helped me gain traction here was positive patient outcomes. There's some ownership that we all have when we work with patients, and so if I'm just some random dude carrying a guitar sometimes, asking a clinician, yeah, I'm gonna go see your patient, I've gotten some really odd looks, especially when I was first here. What helped again establish some of these services was when they realized, oh, there was more to this that happened in the room than this person entertaining this my patient for the day. And so again, positive patient outcomes, being an advocate, being able to give brief elevator speeches. If I'm literally in an elevator or just walking past someone in the hall, and they're like, oh, is that a guitar? It's like, yeah. And what do you do? I'm a music therapist. What's that? Oh, this is what it is. All these small things combined together really help gain some traction.
I'm glad you brought up the piece about how music therapy is rooted in science and that there is a body of research that supports its utility. Can you tell me where you feel the research needs to go in order to really enhance what you do clinically?
Sure. So I think any interaction of the brain with elements of music needs to, and there's a bunch of research on it already, especially in the neurologic music therapy realm, but I do believe that is something that the more research could be focused on. In addition to that, the interplay of the inherent emotionality of music and the reactions and the responses that the brain generates from that. Again, there are pathways, and there are just to study the limbic system and all this stuff and music and the interplay between that, but it's interesting whenever I think you look at research involving something like music, is that it's not quite as black and white as other things. So measuring it, being more objective in a product that you are trying to look at, so is, I think, some of the barriers and some of the difficult things that need to be accounted for, especially when it comes to the emotionality and the music therapy interventions with tailored to addressing some of the emotional needs. Yeah.
That's great. I think we have time for one or two more questions. I have a kind of a fun question. It's going to put you on the spot.
Yeah.
But what, if you had to reflect on your career, what would you say was the most unanticipated reaction to maybe your intervention? I mean, maybe it was a positive or a negative, or I'm just wondering if there was ever a time that somebody responded in a way that you didn't quite anticipate.
So I think, yeah, I can think of it, not a specific example, but this happens sometimes where someone will have some emotional tie, some emotionally charged memory with a song that is not inherently that emotional. So maybe it's a children's song. Maybe it's, again, my personal preference is not the personal preference of everyone. And so maybe it's some artist that, like, I'm not knocking this artist, but like, I don't listen to Katy Perry, for example, but I know that for some people, this could be like the most meaningful music, emotionally, and just like they have a strong emotional ties to it. It's going to make their brain react a little differently when they hear it. And so whenever I have the opportunity, again, to use preferred familiar music, patient preferred familiar music, and see these responses, and I'm like, oh, wow, I wouldn't have thought, Katy Perry had it in her to do that to someone, but here we are. So I think whenever those situations happen, it's a good check-in for me of, that we all are different.
Yeah, absolutely. Well, I don't have any more questions. I have really enjoyed this very much. I've learned a lot. I really kind of hope that we can create more of a collaboration here, especially maybe some of our other clinical practices here on campus. So thank you for a really wonderful opportunity. And yeah, thank you, Ryan. We
Awesome.
appreciate it so much.
You got it. Thank you very much.
Brian and Amy, thank you very much. And to all of our attendees, this is a wonderful session. Please look for future sessions to be announced that will be after the holiday break. And again, we've recorded this session, so we'll be happy to make all the attendees aware of how they can access it. And thank you again. This was truly wonderful. Best wishes, Ryan, and the rest of your day. Sounds like it's busy there in the hospital.
A little bit. It's fine. Thank you, guys.
Thank you.